Okay, so thank you, Lior. Again, I appreciate being invited to speak at this event. The presentation is supported by Invite and Tiva. And I have no conflicts of interest to disclose. I am currently a member of the NCCN breast ovarian cancer panel. So just going through an overview of what I'm going to talk about, I'm going to start with some perspectives on emerging management and treatment implications based on BRCA test results, because I do think things are changing now. And then I'm going to go through some clinical cases, and within that, within the presentation, I'm going to give you some updates on the NCCN guidelines that have just come out in the last few months, and then go through an overview of the genomic advances. And some of this will overlap with what Steve just mentioned, but I'll fly through some of my slides. So looking at genetic testing implications for testing in the past were really based on risk assessment. So we were really trying to go for prevention of cancers, whereas now it's actually important in the active treatment setting, which is a change, I think, that we've experienced over the last few years. And as a result, testing at point of care has become a lot more important because it can make people eligible for clinical trials in various different settings. And I wanted to kind of go through some cases where that is the case. Now, when we're thinking of current management options for BRCA mutation carriers, it spans the entire cancer prevention and control spectrum, but really what I wanted to focus on for the moment was cancer treatments. So when we're thinking about personalized treatments based on BRCA mutation status, there was a study that was published, I think in 2008, it was the Polish data. And what they did was they looked at partial and complete response in a group of BRCA1 mutation carriers as well as non-carriers. And what they found was, pretty high response rates overall. But when they subdivided the data, looking at those that got taxanes versus those that got other DNA damaging agents, again, you saw a huge difference where with the BRCA mutation carriers, they didn't seem to respond as well to taxanes. But again, even with this lack of efficacy to taxanes potentially, I do think we still need some confirmatory studies to really see how true this is. The other thing is platinum-based agents. Again, for a long time now, we've known that ovarian cancer survival in BRCA mutation carriers seems to be better. And one of the hypotheses out there is we think it's because of chemosensitivity to the platinum-based agents. And this was a study that came out of Cedars-Sinai, where it was based on 605 women, including 213 BRCA mutation carriers. And what they found was a pretty big survival difference. In carriers, it was almost 54 months, versus non-carriers, it was 38 months. And the effect was mainly due to the later stage cases, as you can see. This is where the curve splits up. And BRCA carriers had a decreased mortality by about 28%. So that has prompted some studies looking at platinum-based agents in breast cancer. And again, from the Polish group, this was published in JCO in 2010, and what they found was when they did a chart review, again, the responders there was a much higher response rate in people who had platinum-based agents. That same year, it was 2010 in JCO, the Harvard group published on triple-negative disease, and what they found was it was based on 28 women with triple-negative breast cancers. 6 of them achieved complete clinical response, so 22%. But what was interesting here is of these 6 people, there were 2 BRCA mutation carriers, and in the entire set, there were only 2 BRCA mutation carriers. So again, it looks like platinum-based agents may have utility in BRCA mutation carriers, and those are the area of active clinical trials as well. Now, again, many of us know about the PARP inhibitors, and this was a study published in the New England Journal of Medicine a few years back, and it was a phase 1 trial, but again, it had very, very exciting results where there was a partial and complete response in a variety of individuals with different tumor types, but that were BRCA mutation carriers. And as we all know, there is a rationale for targeted treatments in BRCA carriers with PARP inhibitors. And when we're thinking about it big picture-wise, there are two main pathways to DNA repair, the homologous recombination and the base excision repair pathway. And in BRCA mutation carriers, we know that the homologous recombination pathway is defective, but the base excision pathway still works. So, again, that's a big picture of the BRCA situation. However, when we have a PARP inhibitor at play, so if you have someone with a BRCA mutation, but they also are treated with a PARP inhibitor that impacts the base excision repair pathway, it leads to selective cell death in the tumor, and that's what we call synthetic lethality. So the bottom line here is really treatment based on whether someone has a BRCA mutation is on the horizon. I think it's already here. And we're not just talking about the pre-surgical setting, because we've done that for a while where people may want to know their BRCA status before making a surgical decision, but now we're really talking about treatments. So here's the first family I wanted to present. This is a family that we saw in our clinic within the last few months. And the patient was diagnosed with stage 3 ovarian cancer. She's right here. And she completed conventional chemotherapy, referred following the treatment when they took a complete family history. And the risk models predicted up to a 93% chance of testing positive for a BRCA mutation. And again, conventionally, our gynocs have really not thought about treatment, the BRCA status being important in the treatment setting. Again, in this case, she was found to have a BRCA1 mutation, which was not a surprise given the family history. But this is a patient that would have qualified for a trial that is active at our center, and they realized it after the fact. We have an open olaparib trial that she could have benefited from or been offered. So per national guidelines in the US, every individual with ovarian cancer is supposed to get, or at least supposed to be offered BRCA testing. And had this patient been offered the testing, she could have been offered this trial. So identification is absolutely important in these kinds of cases. So here's another case that we saw within the last few months. Here's a patient, age 34, with ovarian cancer, stage 3 ovarian cancer. And she was actually referred following initial treatment because she'd had a good response to treatment. And they wanted to see if she was a BRCA carrier to determine eligibility for a PARP trial. So she was BRCA1 positive. And again, you don't see a striking family history here. There's a father with prostate cancer, diagnosed at age 57. Again, kind of interesting. We knew she was going to be a carrier because her unaffected sister at the age of 30 was tested first out in the community after her sister had been diagnosed with ovarian cancer. And she was BRCA1 positive. And at the time we saw her, this 30-year-old had already been thinking of an oophorectomy. So, again, many issues with that. So there is a trial open again at Moffitt where it's maintenance therapy for individuals who have a good response to initial ovarian cancer treatment. And again, this patient is on this trial now. And then the third trial that is open at our institution is a PARP trial for stage 4 breast cancers. And, again, what the oncologists tell me is they have had a tremendous response to treatment in BRCA carriers. They've had people on study for over a year, which is unheard of from what the oncologists tell me. So I'll move on to different cases that we've seen through our clinical population. I'm going to start actually my cases with the pre-panel era. We've been doing multi-gene testing probably for the last 2.5 years or so. But these cases are a little older than that. So here's the reason for referral here was a 39-year-old with DCIS, and BRCA testing was done, including the comprehensive testing as well as the del-dup testing, which we call BART, or we used to call BART when Myriad was doing the testing, and no mutation was detected. But there was this entire family history that hadn't been taken on the front end. So this kind of brings up, when you have a no mutation detected result, it can be a true negative, but it can also be an uninformative, and this is a classic case of an uninformative test result. So again, we all know negative result does not mean no risk, and this person certainly would have been at high risk regardless. So following the negative BRCA result, the treatment was initiated with a lumpectomy and radiation, and subsequently it was actually the radiation oncologist that figured out that there was more family history and referred for genetic counseling. She's got a TP53 mutation. So after counseling, she wanted to test her daughter, who's 5 years old, and again, there are some screening protocols that are available, so daughter also, 5-year-old daughter, has it. This patient was, so the sister got diagnosed with breast cancer, again, DCIS, at age 37. So this was before we were doing the multi-gene testing. So what I did was, I did the TP50, this was to make a surgical decision in this patient, because she already knew there was a TP53 mutation in the family. But you see that there's family history on both sides of the family. So because it was for a surgical decision, we had to do the TP53 testing. We also did the BRCA testing. And she actually does have the mutation as well, and she chose a bilateral mastectomy for her treatment because of the, she wanted to avoid the radiation treatment. And subsequently, both her 22-year-old daughter as well as her sister have also been diagnosed with the same TP53 mutation. So this is a situation where I wish we did have the multi-gene testing available at that time, because this family history certainly is extensive enough that you'd want to do BRCA, but you'd want to think of other things as well. So again, the case also illustrates when you diagnose someone following initiation of radiation, like what happened in the first individual in the family, versus prior to initiation of treatment in the second patient, there are some ramifications, because in TP53 mutation carriers, you want to be able to avoid radiation wherever possible. And then again, with NCCN guidelines, what we say is therapeutic radiation therapy for cancer should be avoided when possible. So again, the second patient was able to benefit from this information. So here's another case. Patient was referred right here for a personal and family history of breast cancer. She was a 43-year-old with a recent diagnosis of DCIS, and she was actually sent to us to make a surgical decision. So what we noticed when we took the family history was she did have a history of thyroid nodules, lipomas, and fibrocystic breast disease. And because it was a surgical decision, we wanted to do BRCA, but this is also suggestive of PTEN. So BRCA came back negative, PTEN was positive. So had we had multi-gene tests available, again, the perfect case where this makes a lot of sense. When we look at the revised criteria for PTEN, again, this is kind of a changing landscape where some of the things we used to think of typically, we don't score as highly, versus there is evidence now to include other things like the autism spectrum disorders, the colon cancers, the renal cancers. So again, I think we are better able to distinguish the phenotype now, but I think there is a lot of heterogeneity in what we see. When we look at the updated guidelines, we've actually made some changes to the screening regimen. And again, when we're looking at men and women, we do think that the colonoscopies should be started at a fairly young age. The renal ultrasound has also been added to that regimen, as well as a psychomotor testing for children when there are indications. So looking at the patient follow-up, it is complicated to manage these patients who are at risk for several different conditions when they have a PTEN mutation. So one of our surgeons at Moffitt has taken ownership of this patient and is conducting the multidisciplinary care. We've also referred her to Cleveland Clinic, who are the world experts in this condition. Now, colonoscopy in this individual identified multiple hyperplastic polyps after this diagnosis was made, and then renal ultrasound identified an early stage kidney disease. So again, you can see here how doing the complete assessment really does make a difference in terms of patient care. So when we're thinking of breast cancer, we all know BRCA is the major player in inherited breast cancer. But there are other genes that are involved in inherited breast cancer as well. And you know what I would say is, since we've started doing the multi-gene tests, we are finding probably the majority of our findings that are unexpected are the TP53 and the PTENs. There are cases that we're finding that we would not have found without doing the multi-gene tests. Again, it's interesting that Steve mentioned the Lynch syndrome genes, because we found a bunch of those as well in the breast cancer cases that we've tested. So again, that's going to be an evolving story that I think will be very interesting. So to put things into perspective, the structure of DNA was only discovered in 1953. In 2003, the Human Genome Project was declared complete. So that was pretty quick to get to the entire genetic code. Since then, what we've been doing is trying to figure out what this genetic code means. And I think we have a lot more to learn here. Again, going through what Steve kind of told you already, the costs have plummeted. That's what's driving this whole technology, the ability to test at this scope. But even though the costs are dropping, the interpretation is still very, very expensive because we still need to figure out what we're doing. And with next generation sequencing, again, Steve already covered this, but Sanger sequencing, the cost was a lot more and it took a lot more time. Whereas with next gen sequencing, you're doing everything in parallel, you're miniaturizing everything. So it just takes a short amount of time and you can do a lot more. And looking at the timeline of how things have changed, again, the discovery of the BRCA genes was in the early to mid-90s. Myriad Genetics, the company that had the patent on the gene in the US, started enforcing it towards the late 90s. Next-gen sequencers became available about a decade ago, but the targeted multi-gene panels only became available to us commercially in March of 2012. In May of 2013, I don't know how it impacted things here, but in the US, you know, there was a lot of awareness after the Angelina Jolie disclosure of her BRCA1 mutation. The Supreme Court ruling, again, was huge for us because, again, it gave us the ability to choose different labs from whom we could order the testing. And this is a study that was an early glimpse of the potential to detect a wide variety of mutations. This is a Walsh et al. Paper from 2011 led by Mary Claire King's group, where what they did was they tested 360 women with ovarian, peritoneal, and fallopian tube cancers and found 24% had some sort of germline mutation. Granted, the majority were in BRCA1 and BRCA2, but there were some other ones that were important as well. So again, I think that told us that we were going to be finding a lot more as we did this kind of testing. So what's changed with testing now compared to a few years ago is a few years ago we'd have to do the first test. If it was negative, then we did the second test and so on, which was often cost prohibitive. Whereas now we're doing a lot of testing all on the front end, which is much cheaper, but you do have to think about the results interpretation, as well as the time frame sometimes can be a lot longer, although that is even starting to become less of a barrier. So the way I think about it is you have your certain genes that are low or moderate penetrance genes, which are really features of familial cancer rather than the inherited cancer the way we think of it, versus your high penetrance genes where, you know, they're clearly actionable genes. And when we're doing this kind of testing, it is important to talk about mutation versus variant because your variant rate is going to be higher. But again, keeping it in perspective that even when you have variants, variants are normal in your genetic code. So we're not at this point able to differentiate what is a variant and what is normal versus what is a mutation all the time. 80% of the time with these variants, they will be reclassified as normal. So again, talking about this with patients is very important on the front end. And actionable versus not as actionable is, again, very important because all genes are not equal, and the patient needs to realize that before going forward with the testing. So the way I explain it is, again, the main things that we are looking for is a mutation in an actionable gene. The rest of the things we may find, but in terms of clinical utility, that's where there's going to be the most clinical utility. And what I don't have on the slide is the other thing that's really important to focus on is not finding a mutation in a gene which was clinically indicated, because again, that gives the patient a sense of reassurance. So those would be the two things that we really emphasize during the appointment and even during the disclosure, rather than going through, okay, well, you had 5 variants in these genes that don't necessarily matter. We would go through, hey, here is the negative, the genes for which you were negative where you didn't find a mutation. So, again, the counseling we've had to kind of learn on the fly, because when we started doing this, I think we're still trying to develop the best counseling model, and there are publications out there. But I think with time we've learned how to advise patients how to deal with the pre-test counseling as well as the disclosure appointments. So, again, I like this slide. It's like this, Mrs. Cameron. The results are negative, but that doesn't mean not positive exactly, nor is it not negative. We wouldn't want a double negative there, would we? So, again, you just have to be our experience is you have to be very clear with the patients up front to kind of say, okay, well, this is what matters. This is what you might get that's not really going to matter all that much. So going through the 2014 NCCN guidelines, we did expand the multi-gene testing section. But, again, just to summarize, we gave an overview of multi-gene testing, points in favor, limitations, issues to consider, and then general recommendations. So again, if you're wanting to learn more about this, there is some information that I think is pretty balanced in there. The other article that I would direct you to is there's a review that came out within the last couple of months, the gene panel testing for inherited cancer risk. And really what they went through is advantages versus disadvantages. And on top of that, they kind of went through pre-test discussion points, which I think is really, really important as well, because you don't counsel the same way when you're doing the multi-gene testing compared to when you're doing the BRCA focus testing or the single gene testing. So going on to another family, and this is, these cases are going to be the ones where we did do the multi-gene test. So this is a 49-year-old, 49-year-old with 2 left breast primaries, treated with mastectomy, chemo, radiation. So she came to us after treatment. And she was really referred to identify future personal and family cancer risks. And so you see a mom here with breast cancer at age 72. I don't know what's going on here. Maternal half-uncle with brain cancer in his 30s. So again, the only thing in the past that we would have ordered for this patient would have been BRCA. We wouldn't have been able to get coverage for anything else. But this patient does have a PTEN mutation. When we disclosed this information to the patient, what was interesting was, during the disclosure appointment, she had talked to her mom after the appointment. She found out her mom had had colonoscopies in the last year and had colon polyps detected. And then her son had always had a large head, and he was in the autism spectrum disorder. Again, we asked these questions as a standard, but we didn't capture that during the initial counseling appointment. So in terms of follow-up, we referred to a physician who serves as her medical home, because it's got to be multidisciplinary care for this patient. And we referred the son to pediatrics for genetic counseling and potentially testing. And again, the patient was really happy because this is a means by which she can now get services for her son, because he's probably got a diagnosis, and in the US, it becomes much easier when you have a diagnosis to get medical services for children. So here's another patient, 65-year-old, recently diagnosed with right DCIS, and she'd had a prior diagnosis of left DCIS at age 56. There is a family history of breast cancer, both in her mother and grandmother, who were diagnosed in their 60s but died the year they were diagnosed, which suggests that it may be an aggressive phenotype. And there's, a couple other breast cancers in the family, including a male breast cancer. So we ordered one of the comprehensive cancer panels, and we found a PALB2 mutation. So again, this gene has been getting a lot of press over the last few months. It is the breast cancer risk by age 70 is reported somewhere between 33 and 58%. It does seem to be modified by family history. There may be an association with pancreatic cancer risk as well. Triple negative disease looks like it may be more common in PALB2 mutation carriers, and aggressive disease, there may be some association with that as well. This is a New England Journal paper that I'm sure most of you saw, where they looked at 154 families with PALB2 mutations. And again, the breast cancer risk, like I already said, was modified based on the family history that was present. But when we're looking at 2+ first-degree relatives, the risk was reported as 58%, which is pretty high. I mean, it overlaps with BRCA2 cancer risks. There was an association with triple-negative disease that they saw in this study. And then the male breast cancer risks, again, looked like they were elevated. But again, you see the wide confidence intervals. So here is another family that we saw in our clinic, again, in the last year or so, 43-year-old, referred based on personal history of early onset breast cancer. So she was diagnosed with breast cancer at age 43, and she was a very, very anxious patient. But she had a type of insurance that will not cover genetic testing. And again, in the US, when you have the situation, it's Medicaid insurance, you can't get testing from any of the labs, even if there is a financial need. So when she had no insurance, she came in. That's what our genetic counselor had advised her to do. And we can actually get people covered if they don't have any insurance, based on the financial assistance programs available. And we tested her through MyRisk, which is the Myriad test, multi-gene test. And she has a PMS2 mutation. And this has happened to us a few times, which is why, again, Steve's data is very interesting to us as well. And we know with a Lynch mutation, there are specific guidelines to follow. So this definitely changed the way we would manage her moving forward. Now, I just wanted to touch on hereditary colon cancer very briefly. Again, we published a paper earlier this year, and this was based on the data set from one of the commercial testing labs that have been doing the multi-gene testing for over 2 years. So what we had was, again, it was a secondary analysis. These were not our patients. 586 participants, 10.4% with pathogenic mutations, 20% VUS rate. So again, the VUS rate is definitely high. Of the 61 pathogenic mutation carriers, again, the CHEK2s, the heterozygous, MUT-YH mutations aren't necessarily of clinical relevance all the time. So we took those out, but that still left us with 42 actionable mutations. So that's a rate of about 7.2%. 71% met syndrome-based guidelines for testing, but about 30% did not meet clinical testing guidelines. So again, we are picking up things that we wouldn't have picked up without the multi-gene test. So one of the last things I wanted to just mention is when we're doing these tests, we do want to know about cost effectiveness, because cost is the driver of many things. And I think the data is being collected now, but this was one of the abstracts that was presented at the recent ASHG meeting by one of my colleagues out in University of Washington. And what they found here was, compared to testing for only Lynch-associated gene, it does look like there is increased cost effectiveness with addition of autosomal dominant high penetrance genes. When you add the high penetrance autosomal recessive colorectal cancer genes, it seems to become more cost effective. And then when you add the low penetrance autosomal dominant genes, again, it goes up a little bit, but it's still lower than just doing the Lynch-associated genes. This is preliminary data. I'm not sure how they factored in the universal tumor screening for Lynch syndrome that we're supposed to do as well. So again, preliminary data, but I think this is where the field is going. I think we want to figure this out. So we are noticing a paradigm shift, and we see it in our own clinics where, You know, in the past, what we have typically been trained to do is figure out a potential our hypothesis or a differential diagnosis, then order our appropriate test, and then interpret the findings, and then refine our differential diagnosis to see what else should be done. But with predictive medicine, what's happening is we're almost testing first, and then we're looking back to see if the testing makes sense. And that's what we've had to do with many of our cases, where we're finding these things that we really weren't expecting. And again, I don't know how well the disease phenotypes for these genes are characterized anyways, because we've really been testing people that are obvious versus, you know, what about the ones where you don't have a typical family history? But that's what we're seeing more and more. So again, future of predictive medicine, we have a fortune teller here saying to her client, but if you want the real lowdown, we'll need some of your DNA. So thank you. And I think, what, a couple of questions?
I will shout. That's what I do. Several comments. First of all, the R3378 mutation is present in about 0.3% of the population of the South part of Brazil. And it's a predominant mutation. Someone has tracked it down. The overall survival of ovarian cancer cases for BRCA1 and BRCA2 carrier is better after 5 years, but that disappears after 10 years. That JCO paper from 2012. And that's, by the way, includes probably 1/3 of Israeli ovarian cancer cases. The first author is Angela Shipman, the work with that.
And Stephen's paper as well in JNCI was the same thing. We don't know about long-term survival.
And the one thing that needs to be stated about the PARP inhibitor and the triple negative and BRCA who have partial pathological complete response, but that's the data of Bella Kaufman and Shami Shimon from the Oncology Institute that was presented at the last ASCO. The pathological complete response does not correlate with overall survival. So the overall survival is the same whether you have a pathological complete response or not. So that's something to look into.
No, excellent points.
Oh, okay.
All right, thank you for the presentation. I just wonder, how do you counsel a 5-year-old child of this patient?
Actually, it wasn't our patient, it was our colleagues in South Florida, but really, even if it was us, it would be counseling the parents. I mean, with the child, you can't counsel a 5-year-old child. So you go through the pros and cons, and then, you know, again, from a guideline standpoint, we will not test a child unless it will make a difference in terms of their medical management. TP53 is kind of shaky because we don't know for sure that it makes a difference, but there was that Villani paper from a few years back where they did find that an intensive screening regimen detected cancers earlier. So we do have some studies that are active where we can enroll children into trials. So that would be the rationale for doing it.
How often do you find that parents want to know the status of a child for adult onset disease? Is that commonly something parents ask to know, or is it commonly something they opt out?
They come in thinking that, like when they come in for the genetic counseling appointment, they just assume if they're positive, they're going to test their children. So you kind of have to explain on the front end, well, no, we're not going to test your children until they're 18 years old. And then when you go through, okay, well, why would you test them, and the pros and the cons and the insurance implications, they get it right away. But they haven't thought that through when they're coming in. I don't know, is that the same, Eitan, that you see?
Pretty much the same here, only we limit the testing for adult onset disorders to 25, which is, you know, we don't offer mammograms or MRI for the age.
That's exactly what we do. I mean, our issue is sometimes people insist that they want to know, in which case we will test them at age 18, but we try and hold off till 25. Same thing. Okay, thank you.